Let's jump right into high-yield renal acid base and electrolyte management. We're strictly covering the Step 2 CK next best step decision logic.
For our agenda today, we're hitting acid-base interpretation logic, metabolic acidosis and RTAs, mixed acid-base disorders, metabolic alkalosis branching, sodium disorders and volume, and finally potassium and mineral traps.
Starting with Section 1, acid-base interpretation logic.
The order of operations here is strict. First, you read the pH. Next, you decide whether the PCO2 or the bicarbonate actually explains that pH. This confirms the primary disorder and checks for compensation. Then, if you've got a metabolic acidosis on your hands, you immediately calculate the anion gap. You need to remember that sodium bicarbonate therapy is severely restricted on the exam. It is only for severe acute metabolic acidosis where the pH drops below 7.1. If the pH is above 7.1, the risks of myocardial depression simply outweigh the small benefits. So whatever you do, don't choose sodium bicarbonate for a routine acidosis.
Moving right into Section 2, metabolic acidosis and RTAs.
If you calculate a high anion gap, that means there's an accumulation of unmeasured acids. Hypoperfusion usually indicates lactic acidosis from shock or sepsis. Other classic causes are ketoacidosis, uremia, toxic alcohols, salicylates, and post-ictal lactic acidosis. Rely on associated clinical clues here. For example, if you see an osmolality gap along with urinary calcium oxalate crystals, think ethylene glycol. If there are visual symptoms, that points straight to methanol. By contrast, a normal gap implies a hyperchloremic metabolic acidosis, which comes from either bicarbonate loss or impaired acid excretion. Your key causes to watch out for here are severe diarrhea, renal tubular acidosis, and Addison disease. Now for the RTAs. Type 1 distal RTA involves impaired hydrogen secretion and gives you a urine pH above 5.5. You treat that with alkali. Type 2 proximal RTA involves losing bicarbonate and can show up alongside Fanconi syndrome. You treat that with potassium citrate. Then there's type 4, which is hyporeninemic hypoaldosteronism. The classic test presentation is an elderly diabetic with mild renal insufficiency, hyperkalemia, and a normal gap acidosis. Treat type 4 by addressing the potassium levels and the underlying mineralocorticoid physiology.
On to Section 3, mixed acid-base disorders. Keep in mind a near normal pH can easily hide two simultaneous pathological processes. For instance, salicylates classically cause a metabolic acidosis combined with a respiratory alkalosis. DKA presenting with vomiting will give you a high gap acidosis mixed with a metabolic alkalosis. And COPD combined with overdiuresis leads to a respiratory acidosis plus a metabolic alkalosis. The takeaway? You have to compare the PaCO2 and bicarbonate directions rather than just trusting the pH alone.
Next is Section 4, metabolic alkalosis branching pathways. When you're tackling metabolic alkalosis, urine chloride is your key diagnostic tool. A urine chloride below 20 suggests a saline-responsive disease. Think things like vomiting, gastric suction, remote diuretic use, or general chloride depletion. You treat those saline-responsive cases with isotonic saline and potassium. On the flip side, saline-resistant disease presents with a urine chloride above 20. This bucket includes primary aldosteronism, Cushing's syndrome, severe hypokalemia, or an active diuretic effect. Just a quick note here, recent diuretic use can actually temporarily raise that urine chloride, so watch out for that in the vignette.
Section 5, sodium disorders and volume. When evaluating hyponatremia, the algorithm is strict. First, check the serum osmolality, then urine osmolality, then urine sodium, volume status, and finally symptoms. For hypernatremia, which is essentially a water deficit, if the patient is hypovolemic or in shock, always give isotonic fluid first to restore volume before you start any free water correction. There is a hard threshold for 3% hypertonic saline. It is strictly reserved for severe symptomatic hyponatremia. We're talking presentations with a seizure, coma, or severe neurologic symptoms. And of course, you must correct it slowly to avoid causing osmotic demyelination. Finally, Section 6, potassium, calcium, magnesium, and phosphate traps. The ECG progression for hyperkalemia is classic. Peaked T waves, then PR prolongation, QRS widening, a sine wave, and eventually a rest. For severe elevation or any ECG changes, your first move is giving calcium for membrane stabilization. After that, give insulin with glucose, a beta agonist, therapies for potassium removal, and consider dialysis if it's refractory. On the other hand, hypokalemia causes weakness, U waves, ST depression, and arrhythmias. You need to know the AIOU criteria for urgent dialysis cold. These are acidosis, with a pH below 7.1, electrolytes, like a potassium above 6.5, intoxicants, fluid overload that's refractory to diuretics, and uremia. Now for a very high-yield trap. Hypomagnesemia causes refractory hypokalemia and hypocalcemia. If potassium or calcium aren't correct, you must replete the underlying magnesium deficit. For calcium disorders, a hypercalcemia workup always starts by confirming the calcium level and checking the PTH. Severe symptomatic hypercalcemia requires IV fluids, calcitonin, and a bisphosphonate. Conversely, hypocalcemia with tetany, seizure, or a prolonged QT interval requires IV calcium. Finally, phosphate disorders typically show up in scenarios like renal failure, refeeding syndrome, tumor lysis, and rhabdomyolysis.